Welcome to another episode of Empower Speaks Healthcare Talks. We actually have a very special episode today for two reasons. One, this is going to be the third and last pre-conference episode for the FHLIP Conference, which is the Future of Health Leadership, Information, and Policy Conference with the University of Toronto. So as you know, we've had a couple of special episodes, so this is going to be the third and last one. And the second reason that this episode is so amazing and so special is because we're going to have our guest, Dr. Darren Larsen. For those of you that have been following us, you may know that he was our first guest when we started the Empower Speaks Healthcare Talks podcast. So I'm super excited to have him. We had him as the first, and now we're going to wrap up the FHLIP series with him as we wrap up today. And so as always, I'm going to give you a bit of background information. What is Empower Speaks Healthcare Talks? Why are we doing this partnership with the University of Toronto for the FHLIP conference? And then I'm going to hand it over to Darren, and we're going to pick his brain a little bit about the conference and also about other things, all healthcare. So what is Empower Speaks Healthcare Talks? The idea is to have conversations and disseminate knowledge. Whether you're a patient, whether you're a clinician, whether you're in leadership or senior leadership within the healthcare ecosystem, or you're an entrepreneur, we bring you to the table to have these conversations so that we can dissect some of the challenges and better equip ourselves and understand how to navigate the healthcare system. Now, what is another way to disseminate knowledge? It's conferences. And so that's why we thought, why not partner with the FHLIP conference to disseminate knowledge through them? So this is to give you a taste about it, get you excited for it. So that way we can encourage you to attend the FHLIP conference this year. And so like I mentioned, we have a very special guest, Dr. Darren Larsen. So he is a family physician by background. He is still practicing. So there's that piece, but also with the University of Toronto, he's an adjunct professor. And so we're going to pick his brain a little bit. So Darren, welcome to the podcast again.
Yeah, thanks, Fahreen, and also congratulations on the success of this series up till now. Like, having been your first, I had no idea, but now I know. And it's been a really interesting and important, I think, series of conversations you're having with people over the last couple of years. So really happy and proud to be back with you today.
Awesome. Thank you so much. So let's get started. So we're going to start off by talking about the FHLIP conference. And as I promised, we will, pick his brain a little bit later. So when it comes to the FHLIP conference, why do you think this conference is so important, or the value of it? And also, how does it differ from other conferences that you've kind of seen and been part of over the years even?
That's a great question. So the FHLIP conference is a very different event from the standard sort of conference you might be used to that's more commercially oriented or vendor oriented or really directed around a specific discrete line of thinking. So when we're at the university and we're teaching these incredible students who come through our master's health information program, we get to see all kinds of big ideas come through their various projects, their practicums, the research they do for the papers. And it was thought probably 3 years ago now that it's about time to try to showcase that activity and bring it to the surface. In other words, really great ideas should never just be put on a paper and placed on a shelf. They need to be scaled and spread. And the idea about this conference is to bring the great ideas of our students and the innovative concepts they have around various topics from their practicums to their research to light and make it accessible to everybody. Also to do it in a way that's fairly academic, but yet also accessible to the average person who isn't attached to the university, who wants to simply learn more about what is probably going to be the cutting edge of thinking in health IT in the next 2 to 3 years. So I was asked to join as a organizing committee member in charge of providing sponsorships, making this conference affordable. Obviously, as a university conference, we need to be self-sustaining, and it's been a pleasure to be involved. This is my third year in the organizing committee, and I think this is the best one we've done yet.
Yeah, I couldn't agree more. Like we've kind of seen it evolve over the years. Like you said, we started this 3 years ago. And I think to your point, it's so important to give this platform to have the students involved. They've been behind the scenes helping us plan it, and also having an opportunity to present, whether it's through their practicum, their capstone, even papers and other pieces of work that they've worked on to build that brand for themselves. And also because they are the future for us. And so I'm dating myself. When I was a student, right? These opportunities, I was able to present at the eHealth conference, but I was able through, at the time, Kareem Khashoggi was one of the professors. Now he's the director of the program, but at that time was able to work with some of the projects he was involved in and be able to participate that way. But to your point, that was, other classmates of mine did not necessarily have those opportunities, but by having the FHLIP conference to give them that platform, I think is so important. Another piece that you said that, this year is going to be the best yet that it has been, and I completely agree with that. And seeing it from its inception 3 years ago to now, what do you think has really evolved? And what do you think why it's so important that it has evolved over the 3 years in those particular areas to be better or to better serve the community when it comes to healthcare?
So yeah, it's a complex question because it goes well beyond what the students are doing, although they are the centerpiece of all of our presentations. This year, we've really focused hard on bringing together industry, public policymakers, and our student body to try to blend and bridge and measure up the ideas that can be going from conceptual to actually practical and put into place. So I think this is a unique environment where the student work is actually the cornerstone of what we're doing. But now around that student work are a whole series of keynote addresses that are incredible with people who are actually changing the system in real time, along with corporate sponsors and a few corporate companies that are actually here probably to find their best talent. And one of the issues we've had with building the startup zone and the networking area is to make sure that our corporate sponsors have a lot of access to what are going to be some of their prime candidates for hiring over the next year to 2 years. In my mind, this blending of those three areas, the policy space from governments, the corporate around, the big businesses that are doing really important work, and then the startups that exist in a smaller scale beneath that, and the students, that's a sweet spot. Nobody else is doing this.
Yeah. No, I think that's so key. Like you said, we always say, have a seat at the table, have all the stakeholders come to a table. We've kind of created that table to your point, right? We have policymakers. So on the government side of things, we have large corporations or healthcare organizations, and then we have the startup culture as well. So to have them as a platform, and then the students, like you said, for them to also build those connections, and then also patients. We've been very intentional about that piece. And you may recall when we were having those conversations where we actually allocated seats or tickets to patients to have them come to the table and have that conversation. And so we were very intentional about that. And I think it's so important. And I always sound like a broken record. I think sometimes when we talk about patients, we always talk about it third party to us. I think we forget that we're all patients. It doesn't matter your profession. It doesn't matter your title. We're all patients. And when we talk about patients, we need to keep that in mind and be mindful of that. And so I appreciate you kind of highlighting that piece about bringing it all together and having all the stakeholders and being one of the unique platforms and conferences that does that.
That's
Now,
exactly
building
it.
off of that, yeah, no, so building off of that, this year's theme is silos to synergies, building bridges. Now, from your perspective, in your opinion, what does that theme actually mean to you?
Yeah, it actually means different things to different people. But for me, we have a real hard time in Canada bringing ideas together and actually creating some common flow. And I think this is because we're a really we've developed over time this culture of pilots, and we want to do a pilot, and it goes somewhere, and then sometimes it runs out of funding, sometimes people run out of steam, sometimes there's just no coordination, and it simply stops. They rarely fail, but they frequently do not move forward. And the idea about these pilots is they all sit in single little silos. I call these bright, shiny things. There are so many people, founders of companies building bright, shiny things that think that their item, their product, their software is going to be the next major wave. It's going to be the Uber of healthcare. And what happens then is they really push and work hard, almost to the point of burnout many times. And there's no place in the healthcare system to absorb that. And what we're trying to do is take some of the shine off the bright, shiny things and say, look, you have a long way to go from doing something very conceptual, relatively ethereal, that's maybe a really strong burning platform in a very small area, sitting in a silo, to bridging the gap toward what is the next phase of scale, then spread, which is essentially implementation. So what we want to try to do with this kind of bridging the gap piece is take the concepts, take the people that are well positioned to actually create, pay for, fund, implement various projects or lines of thought from our student population, and try to create the space where they come together. And I think this is an interesting time. We're going to be seeing a lot of really interesting posters that are very quick presentations, some longer, deeper assessments and deeper dives into the work that's been done from both our executive stream and our regular master stream. And the idea there is to bring bright ideas to the surface and present them to people who may have influence. And that influence often comes with a funding piece or a potential, corporate sponsor, maybe even venture capital, maybe a series of people that can help them devise and create their thinking at one level higher that's going to get them even closer to implementation. And then ultimately what you want is these really great ideas to land. And when they land, they may have a natural lifespan and they may not go on forever, but the ones that deserve to go on forever will. And we just want to bridge that space between the idea and what is sometimes seen as a very academic perspective and the reality of implementation, getting down into practice and seeing what these things actually do, then scaling it up and moving it out. For the people that are creating these ideas, whether they lead to a startup or whatever, this is a golden opportunity because there aren't many other places for that to happen. And I think that the beauty of this is still rooted somewhat in academics. There's a bit of an academic purity there that we don't see in, say, things like hackathons or some of the more business-oriented events that bring venture capitalists together with founders, et cetera. So we have the luxury of a bit of a breath and we can take a deeper dive. We can talk more academically before we get people into the perspective of what happens next. And, we'll see where that goes. I think it's sometimes up to the founders, the students, the bright idea makers to really present what they want to do and how to bring it forward for longer. But we also have now some great policy-oriented people that are coming from government agencies, companies that are listening. And the big goal there is for them to be able to listen and say, we think we have some place for you. And let's see if we can help you speed the process up of going from bright idea to something in hand to something on the street.
Yeah, no, I think that's incredible. And I love how you painted that full picture because you're right. When you think of the theme, silos to synergies, building bridges, you can take it in so many different ways. I think a very common one has been more just interoperability and the healthcare system, running in silos. But the way you explain it is such a unique perspective where you said that everyone is in silos. So not just the organizations or where data is stored and how we kind of look at it that way, but the way you said people, the groups of people are also in silos. And so how this conference brings everyone to the table to have these conversations where it's the startups are there, the larger corporations are there, the policymakers are there, the students are there as well to get acquainted with all of that and get that exposure as well. And like you said, and to build it from there. And so I do have a follow-up question to that piece.
Yeah.
So this year we're having our startup zone, which is very exciting. And how you mentioned that there's a lot of startups, but they work in silos and you may think this will be the next Uber for healthcare. But that being said, where they've said with AI, there's been a larger startup culture. What is your opinion in that regard when it comes to healthcare? Do you think that the startup culture will be, is real when it comes to healthcare? That too with AI being involved a bit more? Or what is your thought in general? Because I think we talk a lot and we see a lot more entrepreneurs now and some of it may be just, economic and so people are finding other ways. But I wanted your thoughts on with those moving pieces, whether it's AI, whether it's the economic, situation, whether it's the need in healthcare, just with all those items together, what is your thoughts of the startup culture within healthcare, given that we're going to have a startup zone?
So startups are really strong in Canada. We have innovators everywhere. We have great training programs. We have really great starting points with institutions like Mooney and Vector and Accelerate and all across the country. We have great programs that get things going. What we don't have here in this country, I think because of our publicly funded healthcare system, is the same degree of integration with a business idea as a startup to full on procurement and use, say, in a zone like let's say a health team, even a family health team in an office, never mind Ontario health team or something more broad provincial. And this is a hard place for founders to be. Often we see startups in Canada, not just AI ones, I think that's the latest batch of interesting tools, but basically all the new companies that have come into the market digitally in the last decade, let's say, they get their rooting here and they really don't feel like they succeeded until they started to sell in the US. And admittedly, the US is a much larger market. It's 10 times our size. But the interesting thing about healthcare in the US is they have a far greater tolerance of risk. They're willing to take chances on little things and new things more than we are in Canada. Some of our government procurement related kind of processes are really sticky and hard for startups to even participate in. Like, for instance, some of the major procurements in Ontario require a company to have been in existence for 5 years and to have X number of sales already. And that means startups are essentially excluded. So what we're trying to do now is say, okay, maybe we can create something really interesting that's small, test it in our market, maybe sell it a little bit elsewhere to make sure it also works in other markets. But then once we get that foothold, rapidly cycle it up. And we've seen this happening. I have medical students I've worked with who never did residency. I have residents that never desired practice. They came through medicine to actually learn the craft of healthcare, and they're now using it in the health information technology space to create companies that are doing really interesting things. Some of those are AI, some of them are just I. So we don't even need the artificial intelligence. I just want intelligence for a lot of the things that we do. And you hear me writing about this and talking about this all the time. I need smarter systems. I need things that are actually just going to work from the workflow. Say for me as a physician, or if you're a nurse or you're a healthcare administrator, you want the workflows to be recognized and used. And I think startups look at that and analyze it really, really well. We don't give them an easy path to integration, though. Like, to be honest, when we have kind of monopolies in some of our major products out there, including electronic records and health information systems, it's really hard for startups to kind of wedge their way in. But the ones that have done it have often done it with a workflow that truly matters to the customer. That customer could be a hospital, it could be a clinic. Obviously, if you're going small scale, it's much harder to do the sales because, like, one by one, people would prefer to go bigger. We don't have as much of the big institutional corporate healthcare environment here as they do in Canada, or as they do in the States, I should say. But we are starting to see organizations coming together, primary care networks. We're starting to see these patient-centered medical homes that are popping up in primary care referral and reform processes across the country. We're starting to see organization at a provincial scale about procurement. It means maybe we're going to have to stop letting everyone choose a million different things and start thinking about consolidation. So this is all coming. And I think that's going to make it a little bit easier for startups and for small corporate founders to actually think hard about where they fit in. It's not going to make them easier to sell, probably, because there's still this degree of not really trusting things that are new. And as a doc, I mean, I get this. Like, we are skeptics by training, and we're always trying to think about what if it goes wrong and what's the risk here. In Canada, we're very risk averse and opportunity light. I think conferences like this are trying to change that culture, to say we should be a bit more opportunity heavy and think about risk, not to throw it away, but to mitigate that risk with appropriate interventions that make sure that safety is key and that these products don't fail and hopefully don't subject anything within it, whether there's patients or data or processes, to risk. And that risk is privacy, security, all the regular things. We have had a period of saying no in Canada to a lot of things that are different because we crave stability. And I think that a lot of the startup culture doesn't give us that. Now, on the AI front, as more and more of us are using AI and starting to figure out how to trust it to do really important work for us, I think that will be a frontier that starts to test the limits a little bit. And AI is democratizing. Now, large language models are available to basically anybody who has the time and energy to code it. You don't even have to code yourself now. Products will code for you. You can vibe code any program or app that you want. This is democratization, I think, that we're seeing that will have applications into healthcare. What we don't yet have in healthcare is the ability to trust the outcome. Now, we're testing that really, really closely in some of our work with scribing, for instance, dictations and transcriptions and understanding. We're starting to get into the world of analytics as we're getting more data sets coming together. We're doing things like digital twinning and large-scale analytics on populations and starting at a system level to think about what can come from the ability to process lots and lots of data very quickly, even when it comes from disparate sources and even when it's not coded, right? So the beautiful thing about some of our AI tools that are language-based is that English is a code. If we talk in English, if we write in English, that can be interpreted and analyzed just as easily as an ICD-10 code now with these AI tools. So I think we're just beginning to crack the surface of what that looks like for healthcare. And some of our student presentations have dived in pretty deeply to that. And like, what does AI actually mean? What is it that we are getting ourselves into if we can't necessarily trace a point from A to B within a language model or an algorithm? Are we exposing ourselves to risk? But if it's very reproducible and now we are able to see deeper, can we start using this for different things? So I think we're just getting going. And this is the exciting part about students, is they think about things in an unstructured way that gives them more freedom. to actually consider the possibilities, which we don't get once we're deeply embedded into practice or deeply embedded into our corporate life or even in our major, like government or agency or policy related work.
Yeah, no, that's incredible. No, thank you for that. Like, and I think you hit so many key points there. And the piece where you said that a lot of the founders are physicians who didn't finish their residency. I know a couple as well. And so,
Yeah.
to your point, that's as they were going through their residency, they or medical school, they came across things, and that's what they kind of chased. And because they have that clinical background, it builds that credibility, and they're able to have conversations because not having a clinician at the table is very important. So if you yourself are one, you're able to speak to that. You can address a lot of the pushback or concerns because you've lived it and you
Yeah.
understand it to its core. So I think that's a key point that you mentioned. The other piece where you said about students, because they're newer to the space, they see it with a clear lens. We see it because we were a bit more seasoned. You see all the other pieces. You
Yeah.
see the negative side of it. You see some of the things you have to be cautious about, but they see it in a very unique lens. And so I think to your point, that's very important. And then the other piece that you said, where we have a lot of homegrown technologies, but then the idea is you want to go into the US market because it's larger, it's more lucrative. And despite being in healthcare, there is that business component. I think sometimes we forget that is, as much as it is meant to help people, there is the business side to things. And then healthcare is also still a business when we talk about hospitals or what have you. There all those components still exist, and we have to be mindful of that. And the piece where you said about moving to the States, I wanted to add one component to that. In the past, I've worked at a vendor where we were homegrown downtown Toronto, and then we got acquired by an American company. And that happens quite a bit. But when you get acquired by an American company, your intellectual property, your IP essentially becomes American. And so I think to your point where you were highlighting earlier, where how do we allow the ecosystem within Canada to expand? And so the piece about, the IP, and once you're acquired or bought and you're into the American market or you're acquired by the American market, because a lot of the times that's what they want as a startup, to be acquired or what have you. What is your thought about being homegrown and Canadian, but once you're acquired, that IP becomes American, so to speak? It's no longer Canadian. Any thoughts on that as startups try to navigate that path if they choose to, or if that's able to be a reality for them? Any thoughts on that piece?
Well, let me tell you, I think things have changed in the last year as our friends to the south are in a strange and unpredictable position right now. And that market, despite its size, has been seen more recently as being quite unstable and subject to things like potentially tariffs that we have no control over. So what we're starting to see now with these founders and startups, which is super interesting and I think important, is a more global perspective. It's always been easy to cross the border, like 10 kilometers to our south if you live in Toronto. But now, when that might be more risky or a bit more iffy, they're starting to look outside. What does it look like to sell in the Arab Peninsula, go to Dubai or Saudi or places like that? What does it look like to sell in Africa? One of the biggest developing markets in the world right now, with resources and people and excitement, selling there into Europe. Europe has always been just seemingly a little bit farther away across that big pond, but there's a lot of synergies between the healthcare systems in Europe and in Canada. And I think some of our founders are starting to see that. The time zone difference and the travel difference is perhaps the biggest barrier, but there is more and more acceptance of a global market now rather than thinking the US is the sole point that we have to access just because of proximity and just because of its size.
Yeah, no, it's incredible. I appreciate you sharing that. Yeah, now more of an international market, and we've seen that firsthand. And so, I was even sharing about my experience now moving to a different vendor. We're UK based, and we've been there for 10 years, and now we're in Canada. And so, I think to your point, it is looking at things a bit differently than how we used to previously. So I think that's a very key point. And
Yeah,
so we do have, yeah,
we
go
may
ahead.
not think about where that IP resides as often as you might imagine. I mean, to me, if I'm looking at a really great software product, often I don't know where it's come from in its core source, right? It just simply works for me. It's available in my market. I'm going to potentially use it. And the IP piece now, I think IP is becoming more and more global anyways, as there's so much more sharing and open source, right? Even if you look at the language models that existed through companies like OpenAI at the time that they were actually open, the idea was more of a democratization of that and starting to think, hey, you can use one product in multiple environments and come up with very different things. And each time you use that environment, you're actually making that product smarter and better. That's the beautiful thing about learning systems and language models and machine learning is it does get smarter the more you use it. So I think it's a really interesting mind shift that's going on right now that AI's provoked us at a very rapid pace. Like It's only 3 years ago that I'd never heard of ChatGPT before.
Yeah.
And now I have multiple AI models that I use on a regular basis. I have way too many subscriptions to the major AI models, I have to tell you, because I pick and choose the one I need most for the work I'm doing, and each of them have a slightly different perspective on what they can accomplish. So what's really interesting is now we've gone from not even understanding what an AI tool can do to full-on use of it in ways we don't even recognize. I listened to a podcast recently called Hard Fork. There was a New York Times podcast. There's a fellow on there who tried to go AI free for a week. And it's impossible. He can't even turn his water tap on because AI agents are controlling the chlorination in the water, the pressure in the water. Like, it is now ubiquitous and part of our world. So I think in healthcare, we've got to figure out how to use that to its best capacity. And what we're not seeing right now in our current environment is a widespread acceptance of that. I think largely because it's still a little bit difficult to grab the data from our multiple systems to do the perfect training of those models on the language models, the AI agents, the machine learning tools. They need good data to really know that they're producing outcomes for our population that make sense for our population. Like, we are not the US ethnically, age-wise, politically, socially, demographically, genetically. We're not the US. And so our models need to reflect our population. Just as we learned that the BMI, which was generated, umpteen years ago in a group of 18 to 20-year-old American white military guys, doesn't apply to me in my 60s. So the thing will be, training these tools becomes easier and easier to get access to data, and that data we're starting to see freed up a little bit more now through appropriate legislations. Now new legislation coming federally which will restrict data blocking, which is phenomenal. The ability to move information around to follow the patient is coming, and as that's happening, we're going to see more and more AI tools and the agents that work those tools in the healthcare space. And I think once we start seeing the benefit of being prompted appropriately, of being assisted, of automating many of our really boring and pedantic workflows, we're going to start picking these things up one by one by one. Just like when we talked about AI scribes like only a year ago, or maybe a bit more. For me now, AI scribes are so passe, I don't want to talk about them anymore. There's no reason everyone should not be using these. And if you're not using them, it's only because you're failing to look and open your eyes and find out why. A single thing now that we spend a long time kind of promoting is now basically part of our common workflow. And I think that will be the next thing that happens with office automation and the production of things that are often still very human. And it could be everything from following and tracking a referral, making sure something doesn't fall between the cracks, to automatically generating laboratory requisitions on a schedule for people that need them frequently, to ensuring that we're able to dive deep into data and find rare diseases and think about people who might be helped by some of the newer treatments that come out there. This is all going to be possible with massive computation, which in the past would have taken months and months and months, and huge processing power, and now can be done at the flick of a switch, literally. So we're just getting into this now, and it's super exciting. If you look at one of our papers coming is talking about, how AI is used in radiology, for instance, and the trust environment around that. We're going to see talk about that. Analytics, what do we do with data sets that are getting bigger and bigger and bigger and more clean and more normalized? All of this is going to prime the pump, I think, for healthcare to use intelligence well, and the automated intelligence and artificial intelligence, as well as that gets layered on with more and more clarity and more trust.
Yeah, no, that's incredible. And appreciate you walking that through, like with the biases in terms of the data that's collected and just how, like you said, the computational ability that's changed and evolved. There's one terminology or one theme that in a couple of your responses you've mentioned when it comes to AI is democratize. For the
Right.
audience, do you mind explaining when you use this term throughout and when you refer to it with AI, what do you mean by that from your perspective and within the healthcare ecosystem, how that may serve us better or not?
Yeah. So to me, democratization means that these products are available to everybody. And they become available to everybody because of their ease of use, because of their ability to adapt to who you are. So if I want to do this work in Farsi, I can. If I need something translated from Mandarin, I can do that. It's an opening up and a freeing up of things like data, workflows, et cetera, that cross cultures, cross boundaries, cross geographies. And then you put it in the hands of everybody and you start letting them play with things and see what they can do. So, for instance, a lot of our AI agents that do really fun things, and that could be everything from booking your airplane tickets or planning a trip to the Orient or to Vietnam or to Europe. These things can be done for you with a great degree of assistance now. that we never had access to before. I used to have to plug in and request for every single airplane ticket, every potential hotel, every single tour guide. And now these agents are kind of bringing that together and beginning to think with me. And if I'm a physician and I'm trying to figure out a very complex problem, I'm not expecting any of my tools to solve that problem for me. I want them to think with me. So I am able to now we have new health AI platforms being released by the major vendors. We are able to have a conversation. Help me understand. Help me think through. What am I missing? These are the prompts I'm giving it to these agents now that make me think differently because I have blind spots. And blind spots maybe because of my training, my exposure, just not able to process things quickly enough. It could be having a very complex and unusual patient. So it helps understand the blind spots that I don't have the wherewithal, the time, the speed, or the ability to scan quickly through and then see. So as I'm working with these AI agents in my daily life, we're starting to build partnerships now. And with partnerships comes that trust to say, hey, there's always going to be a human in the room. So I'm not defaulting my decision-making skills to a computer. I am using that computer to help my decision-making skills be more refined, more precise, and more accurate. And when we're dealing with large volume patient loads, for instance, or we're dealing with populations that are maybe you're seeing only once a year for some of them or once every 2 years, it helps ensure that people and ideas and concepts and diseases and things that need to be checked don't fall between the cracks. I could see massive changes in our cancer screening programs and massive changes in our immunization programs just because of the fact that everything can be tracked in the background without me even intellectually being involved until I need to be, or prompting me about things that are important in a patient, given the reams of data that will come from their wearables and their devices and their laboratory tests. I need to be made aware of things that are putting them at risk, and then I can act. So this is what's happening over time with these new tools, these new agents, and us as clinicians starting to figure out how to work with them as partners. And I think that will be more than just a chatbot talking to me in a sycophantic way often or make me feel like, oh, I'm great. It's be more like, help me solve this problem. And then feeding back ideas and data or new prompts for my brain to work better. And this is how I'm using these AI products now. And I think as we start seeing applications toward healthcare, it's going to blow up our ability to analyze, detect, and treat.
Yeah, no, and I think as you gave all those examples, I think it really honed in on the fact that AI will augment your workflows. I think there's a lot of fear when it comes to AI, but I think that having that understanding that the tools are meant to augment, because at the end of the day, it'll still be your discretion as a clinician or what have you to determine what would be the right course of action. So I think through those examples, you explained to the audience when it comes to democratization as well as what it means to use all these tools as a clinician. So those of you in the audience that are clinicians and kind of understanding and worried about some of maybe or concerned or also excited about some of the new tools that are coming, how they can augment your workflow. So I promise,
And
as
make
I
no
promised, I will
mistake,
bring, yeah, go ahead.
Make no mistake, some areas of medicine will change dramatically. Like if I were a pathologist or a radiologist, I'd be very worried about my current work because a lot of that work, the reading of histology, pathology, X-rays, MRIs, is going to be more and more automated, which to me is actually a good thing. We get these well-trained professionals back into the actual work of looking after people, not just looking at images of people. And then we become more hands-on again. We become more interventional. We become more stewards of the masses of thought that are coming together around an individual patient or problem or disease. And we start thinking again as clinicians. So not to say, I'm not trying to disparage, let's say, a well-trained radiologist as not being a clinician, but when you are spending all your time reading films, it may not be that you're spending as much time directly in front of a patient. And what patients need more and more of is that hands-on, involved, care-based work. And I can't wait for the day that my radiology friends come in back into the clinical environment again in a very robust way. And I think that's okay. This is not going to happen overnight anyways. There's going to be a gradual change. Already how we're training residents is changing, knowing that this future is coming. And I think it may not be that, let's say, an AI agent can read all of our complex pathology, but it's going to read a ton of that pathology, and especially the stuff that's normal, very quickly sift through that to get to the things that are abnormal or different. And then that's that's when you start pairing up with your clinician experts to say, hey, this is a signal. I need to look at it more carefully. I might have a degree of diagnoses kind of considerations I want to think about here. Help me analyze that and come up with a faster, stronger, more accurate conclusion. This is what we're going to see in some of our fields. I think even in family medicine, like already my patients are coming into me with their symptom complexes saying, I went to ChatGPT and this is what it's told me. Or I went to Claude and this is what it told me. And actually, I look at that with a great degree of satisfaction, knowing that they are truly interested in their disorder and what's happening to them. And often that information coming to me is now really accurate. It's not like I went to Google and I found 10 ads in the first 10 things that popped up that are trying to sell me something, and now I have to sift through and find out what that is. No, this is actually really good information that's been clarified and referenced and able to work with from the patient perspective. And then from my perspective, I think people doing that kind of research in the background makes my job much easier. And actually, we can focus much more quickly. And if we start working with these AI agents to help explain things better, then it's perfect. It's really perfect.
No, that's incredible. So I have two follow-up questions to that. One about your residents, and then the second about patients. So the first piece was where you said about residents, where you're changing how you train them. And when you say that, do you mean in terms of to be aware about the digital aspects and the AI aspects, or what do you mean where now they're being trained a little different? Because I think in the past they said a lot of things didn't change in medicine when it came to training the physicians like 10 years ago, 20 years ago, you name it. But you're saying now that there's more intention about being cognizant of that, and when they are trained in the residency, do you mind elaborating how that training has changed, or what you guys are being mindful of as you bring the next generation of docs and physicians?
Well, for full disclosure, I'm no longer in a teaching environment. I was at Women's College for 14 years. I resigned this summer as I moved my life more north and was not downtown as much. But generally speaking, I think the use of these products for residents will really be variable depending on the residency that you're in. So, I mean, for instance, there's some very talkative, very kind of involved and one-to-one career paths that will adopt AI far more slowly. So I'm thinking of things like psychiatry. I'm thinking of things like geriatricians. I'm thinking of things that are very hands-on doers like surgeons, for instance. But in family medicine, I have some colleagues right now that have an AI agent going all the time when they're with a patient. They have a three-way conversation, the physician, the patient, and the AI agent around the problems that are at hand. And the prompts that have been given to the AI tool are now telling it to please listen, but offer advice or clarification when it senses that something is not being understood properly or more clarity is needed. And that might mean a verbal prompt. It might mean something printed that can be sent to the patient after the fact. I think we're starting, first of all, our residents are using AI way more than we are as the teachers. So they're, to a degree, teaching us. But we are starting to use these products in clinic now. Obviously, scribes are becoming ubiquitous, but the information that comes from those scribes and the way we use that now to help our patients, for instance, if I have a very complex conversation with a patient and my scribe has created a perfect note for me, I, with a push of button, turn that note into a patient education material. And I embed that into our portal, which they can look at, or if with their permission, I can send it through secure email or our email system, and they can have it at hand all the time. This is revolutionary because we all know that people remember only about 10% of what you talk about during a visit. And when they go home and they scratch their head and go, what was that again? Now they have something with them all the time that they can work with. And as even these conversational agents become more ubiquitous, it's not just a piece of paper with a printout of what we talked about. It's like they can converse with that conversation as well. So that conversation can carry on and say, hey, I got this drug, but in my cabinet, but you recommended this drug. Are they the same or not? And start understanding the overall process of the care. Because let's remember, 99.999% of the care of a patient happens at home with them by themselves and their families, not with me in front of them. So the more we can give them to interact with their data, interact with their knowledge and diagnoses and potential predicaments, and hopefully allay some of their worries with actual facts, the better off we're all going to be. So this is happening now. I'm not saying that we have really focused, dedicated programs in adopting AI within, say, a family medicine residency where I am, but I know these are starting to move forward in some universities, especially with regard to radiology and pathology specifically, because of the tools that are starting to do some of the very, I think, common work, like reading films or reading microscope slides, and that is going to be automated. and which frees up time for the professionals to do different things. So this is a evolutionary process. No one that I know about is doing it perfectly yet. We're all kind of learning in real time together, which is also an exciting space to be.
Yeah, no, it's incredible. And as you were kind of giving that explanation, it kind of ties in again to my second question about the patient side, where you said now that you can give them educational material and empower them that way. So earlier you'd mentioned when you're talking about patients where they will look up, they will put in their own results or they'll ask chat and then they'll show up. What is your perspective on AI on the patient side? Now there's various views. Like if you're going to put in chat, redact your personal information, and so you're able to do so safely as possible or in terms of privacy. But just wanted to pick your brain a bit more on the patient side. So we talked and we went quite into detail about on the clinician side how those AI tools, the various tools that you can use to empower and also augment your workflows. On the patient side, in addition to being able to use chat or being more proactive by doing that, and it's great to see that you were saying usually when I've gone to my family physician, she'll be like, oh, you went to Dr. Google, and that's probably going to be Dr. Chat. But
Right.
just your perspective on the patient side when it comes to AI, also with social determinants of health, do you think that can widen the gap for those that are lower socioeconomic or the opposite? Just your thoughts with AI on the patient side based on what you already did share.
Yeah. So, and there are complexities there, right? So remember, there's all kinds of consent regulations and things. When patients are doing this themselves, they're consenting to their data going into these systems, and I hope they're thinking a little bit about where that system lays and where the data is being processed and used and coming back to them in terms of insights. We certainly do. So any of the AI agents that we're using, whether it be a transcription tool, analytics tool, an office automation tool, all of these tools that we purchase or rent from these companies are actually HIPAA compliant, PIPEDA compliant, GDPR compliant. Like they're compliant at multiple levels internationally, often to make them saleable. So we know that we have safeguards in place, and most of our big companies now that are doing this work do have Canadian data centers. We're not processing through multiple, countries around the world that might be worrisome or threatening. And what we're seeing now is an acceptance of that happening in the background, just as we are accepting that our EMR is doing things safely and that data is being held in a place which is private and secure, et cetera. Now, I think there's still a digital literacy issue that you will touch upon, especially with our kind of social determinants gap situation. It's not so much that many of the things that drive social determinants of health mean that people are not able to consume these products. It's just they have less access to them. Having said that, the more democratized these things become. So, for instance, the more an app like, say, Claude or ChatGPT Health can exist on your phone, and the more easy it is for you to have ongoing conversations and work with it in real time with you all the time, the more that gap narrows. And there is a bias there that some of these people that are challenged from many social determinants areas don't have access to anything. We think they're all going to the library or standing outside Tim Hortons, using their cell phones for free Wi-Fi. My experience working in a downtown teaching hospital, that's not actually the case. That even some of my most, financially challenged patients or culturally disconnected patients are still using their phones to actively connect with the world in the way that makes sense to them. And as these products begin to become more handheld and available wherever they are, it'll be easier for them to do what they want to do. I do worry, though, about some of the stuff that we've been seeing around some of our AI tools, for instance, driving people into psychotic episodes and things. Those are probably extreme edge cases, but they do happen. And I think when we approach digital literacy around how our patients are using these tools, one of our jobs is going to be to help teach them and help guide them to use the products they have on their phone every single day well. And as I'm learning it, they're learning it. This is a combined effort. It won't be smooth and easy sailing from day one, but I think we have to be careful to not assume that people can't access these tools because of their language or their income level, or their educational level, or any of the other social determinants of health issues that exist, because in many cases they have more access than we think they do. So we have to check our own biases and actually simply ask. And if they're bringing me an AI-based, let's say, analysis of their symptom complex, I ask them, where did you do that work? Like, what product did you use it on? And then we might ensure its validity or its confidence, et cetera, by knowing that they're going to a product. Like, do I want their knowledge on Grok? Probably not. For many other reasons, they're largely political. Will I trust, GPT Health or Claude Health To a larger degree, probably yes. And if I'm using that product for things that are going to be medical, always I'm safeguarding against putting, truly personal identifiable information in there regarding individuals. If I can help it, please don't do that. But if we can put in broad conversations around non-identifiable things like a symptom complex that could apply to anybody and get results back from that together with the patient, that's really freeing. So it's interesting because in my clinic, I have Perplexity open on my second screen all the time. And I'm not putting patient information in Perplexity, but Perplexity is making me smarter as that patient says, I had this cream that I got in Costa Rica and it's got a purple and red end on it and it ends in IDE. I'm like, what is that? I type into Perplexity, up pops a series of pictures and names. I'm like, is it this? Is it this? They go, it's that. Okay, now I know what it is you were taking. Now let me take the translation of that Spanish writing on that tube and convert it to English. Let's get smarter together. So I am using these tools now in real time, not for analyzing patient information, but for bringing me more data in real time to help me make better decisions in my diagnoses, in my treatment plans, my medications, et cetera. And I think this is revolutionary. I mean, these tools make me smarter and they do it in a way that allows me to be more engaged with the patient, more involved in their conversation, leaning in deeper to truly listen and analyze with my own brain, because I can quickly get answers on the side that I used to have to scrape through Google Ads to find if I found it at all. So it's pretty remarkable.
No, that's incredible. And I love the example you gave that in your own practice, you will have it open and you make it a very interactive experience for your patients. So like you said, they learn, you learn. And so that being said, do you think this is becoming more common in family medicine? Do you think, or do you think it's more unique to yourself just as an individual personality wise that you prefer to have these interactions with your patients? Or, the other piece where maybe other physicians or family physicians would like to have that same interaction, but as we know, the family physician shortage that they don't have as much time. Like, just your thoughts on that when you share that, me as a patient,
Yeah.
I'm like, I would love to have that where I learn, I can have that conversation open. You have that human side to it as well, because sometimes there's that power imbalance. And so I think you bridge that gap. So I know I asked a lot there, but just your thoughts in general of, having that, being able to do that, or other physicians maybe wanting to do something similar to you, but just don't have, their other factors, the logistics don't allow them to have that same interaction.
Yeah, and I would say we're by no means, the majority of doctors doing that kind of thing is probably very much the minority, and probably those who are more comfortable with technology, gone through the hoops and the snakes and ladders of finding out the right product to use for our practices. But I think this change in that thinking, I think, will be the scribe products that are helping us with our note taking. And as we become used to scribes and the scribes start integrating more with other decision making tools, this is, I think, just going to flow. So, like, we don't have the vast majority of all of us on scribes right now, but I think within a year or year and a half, we're going to be there because it just makes so much sense. And our workflow is so much improved, and the quality of our notes is so much improved by using it. And the price for these things is so low that it makes no business sense not to have it anymore. So, I think we're getting more and more used to these. And just like doctors and nurses who are skeptical do, we never just dive all in for everything. We incrementally pick things, we test it, we use it, we move on. If it doesn't work, we choose another one. If it's better, we hopefully keep our eyes and ears open as to what's new out there that could be helping us. And we learn this in our conferences, and we learn it in our education materials for continuing education, et cetera. But we're not anywhere close to the point of handing over diagnostic challenges to AI agents yet. I don't think they're ready for it yet. They're certainly not primed for us to, like, say, let's say, put a patient chart in it directly. No, 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 no. We can't do that. We have no guarantee, even in the most well protected environments of like data housed in Canada, et cetera, of the privacy of that. Never, never, never. Right now, we're still dealing with more broad ideas, broad concerns, and we're using it. I'm using it now to help me become better, stronger, faster. So what happens then if I'm defaulting to automation tool to help me, find the best drug or the cheapest drug or whatever it's going to be that helps the patient? I'm spending less time focused on that computer just finding data, more time leaning in, having a conversation with the patient. I never set my hands on the keyboard when I'm in front of a patient anymore, basically ever. So my my AI scribe is listening, recording, transcribing, thinking, and I'm simply leaning in, truly asking the right questions. It's freed up me to be a doctor again rather than a transcriptionist. And so I think this is a remarkable thing for those of us who've been in the system for a long time, where we started being, really listening, leaning in kind of people. We moved way in the other direction in the last 20 years about over, I think, documenting and keeping things exactly in the right text field with the right drop down menu and the right click off box because it makes our computers function better. We're now moving back again to the humanizing part of that because the computers are doing this on their own. And this is a remarkable and incredible transformation in how we're going to be doing things, but it won't happen overnight. It takes a long time for us to actually learn to trust these agents. And I want to trust them, but I don't want to over trust them, right? And I'm not going to rely on I read everything that comes out of my scribe, and it doesn't really hallucinate with me anymore, but it does interpret things sometimes slightly differently than I wanted it to, and I can simply correct that. Or sometimes it hears the wrong person saying things because our voices are similar, or we've talked in a quiet tone, and it makes a few mistakes like that based on its input, but that's quickly fixed. So the time it takes for me to for instance, record a note at the end of a visit now has dropped from what would have been about 2 to 3 minutes of typing in a very abbreviated way to literally 20 seconds of reading, correcting, and posting, and having then the ability to take that same note and transform it into a patient tool, a referral note, some kind of document that can be used for family members. Like, all of this is possible with a single click of a button based on that conversation that was just very authentic and real. This, for me, feels like I'm coming home back to my roots of medicine, and I'm allowed to really lean in and get joy again.
No, that's incredible. And I think that's so important what you were saying about the human touch to it, or being able to actually lean in and have that conversation with your patient. Because for several years when I would go to see my family physician, you're right, because she has to document. She walks in, literally her back is facing me because I'm on sitting on the side,
Yes.
and then she's typing and she has to. But like when I was doing my master's in physiotherapy before I got injured at the University of Toronto, when I would do my placements, and our preceptors, they would tell us, they're like, the minute the patient walks in, you have to watch them, right? They could be leaning more to one side.
Yeah. Yeah.
You won't, if I walk in, if I'm going to see a patient and my back is facing them, I will not see that, hey, they're leaning more to one side. Even I remember speaking to another physician where it was at a conference where he said that A, won't be able to replace the piece where he's like, I walk into a room, he's on the pediatric side, a pediatrician, and he's like, I observe which caregiver will be maybe open to the conversation I want to have. He's like, AI can't do that. I need to do that. So I think, to your point, being able to observe more is also
Yeah.
gives you a fuller picture, and allows you to have an informed decision, even clinically, because those are pieces that AI can't see. It's you seeing, it's not them hearing, not anything. So I think it's so beautiful you added that piece, because I think it makes you a stronger clinician having that time to
No
observe
question.
things. Yeah.
No question.
Mhm. Alrighty. So as promised earlier, last year when we had our conversation, some of the themes we spoke about was, the shortage of family physicians. Then we talked a little bit about population health, and we also talked about medical AI scribes. And like you mentioned earlier, and last year too, that it was, low hanging fruit. And now you're like, okay, it's passe now. Now, that being said, that was our conversation a year ago. Now, a year later, are the conversations the same for you? Are there other things within the healthcare ecosystem you are now focused on? And you're like, okay, now this is where we need to focus, and make changes to, or have more momentum to. Any thoughts on that?
Yeah, for me, the next stage of this is going to be automation and back office functions, and sort of the improvement of the workflow and speed and efficiency of the things that we do when we're not with patients. And that is considered a lot of the administrative burden of doctors that's taking so much of our time and robbing us of so much of our joy. So these computerized products now and these digital products are going to free us up from some of the mundane, pedantic work that we simply do all day, every day, or at the end of every day for hours on end, because so much of that is repetitive. So much of that is actually reproducible and can be delegated. And we would, in the old days, delegate to a staff member, but now many of us don't have enough staff members either. So we are left to do it ourselves. And therefore, it drags us into the mud. So these office automation tools that are largely going to be intelligence based and working with our electronic records and working with our other workflows, everything from creating referrals to patient intake tools to answering our telephones to triaging people for the best appropriate visit, whether it be a phone visit, a video visit, an in-person visit. These things are going to be, I think, revolutionary for me in my practice in the next 5 years. So that will free up a lot of energy and time. I don't think it's going to necessarily make it easier for us to see 10% more patients and solve the physician crisis in terms of numbers of warm bodies needed to see numbers of warm bodies in the population. But it's going to allow us to be more focused and more productive in that time that I have with the patient. And it may be that my patient encounter all in, including charting, goes from 15 minutes down to 13, and I have 2 new minutes. If those 2 minutes are used for exploring a new idea, educating myself better, teaching a resident or a student, spending more time on volunteerism, going home to my family earlier, that's all fine. It always doesn't always have to translate into more visits per day. If our visits are smarter, more efficient, more effective, if they match the workflows and needs of patients better and the workflows and needs of our providers better, if we are working in a truly integrated team environment where we have help, then that's what's going to increase patient flow and the ability for us to look after larger numbers of people. We are training more doctors. There's no question. Like, we have 3 new medical schools open this year, another 2 coming. Sorry, 2 open this year, 1 coming next year, another 1 coming the year after that. This is going to increase our number of student trainees, but it does take 8 years for them to get out. And remembering that over half of the students getting into medicine now are women. Women have always been smarter in terms of the numbers of hours they've worked and the ability for them to balance their busy lives with work. And so we're going to need more people to do the same amount of work no matter what, because even the men are saying, hey, I like that lifestyle. I'm going to restrict myself to, you know, 8-hour days or 9-hour days. I'm going to take a day off with my kids. I'm going to be focusing on my teaching or my research, et cetera. So we are still seeing a gap, even though we're training more people. What's going to be interesting, though, is if we really truly figure out how to work as teams and learn how to share that workload and share the expertise of what needs to happen for a patient being done by the person who does that best, not always defaulting to the doctor or the nurse, then this is where we're going to see throughput improve dramatically. And these are some of the programs that are building now: primary care medical homes, our primary care networks, these consolidated primary care models that are going to work well for the first point of access to patients into the system. We still have a lot of work to do in the hospital space, a lot of work in the specialty space. They are still largely working in silos and not integrated into teams. There's a lot of system transformation that needs to be done. But for me, it begins with me being more efficient in the back office function after I become more efficient in the patient interaction function. And then we start getting into larger population perspectives. I'm still very excited about population health and the ability for technology to help us with that. And that's going to be everything from, drug crises on the streets of downtown Toronto, right through to ensuring that none of our diabetics are lost to follow-up. Everything in between. I'm chair of the Federal Cancer Agency. I'm really interested in why our cancer screening rates have leveled off and begin to fall in some areas. How do we pick that up again? How do we ensure that our patients in the far north have equal ability of doing cancer screening as someone living in Rosedale in downtown Toronto? Like, how do we bridge that equity gap? So I think our technology will allow us to do that better if we focus on ensuring the outcomes we get are what we want from it and we expect from it. We can't take our eyes off the prize, and that involves evaluation and very quick real-time understanding of what we're getting out of these products. So it isn't just that more is better. It's not just that more time creates more volume and more ability to see people. I want the quality of that experience to improve. I want the efficiency of all of that start to finish patient encounter to be better for all of us. And then what we're going to see is doctors not burning out, doctors not being as tired and exhausted, people starting to find the joy in the work they're doing every day because they're relating to people again, which is what got us all into this profession in the first place. So we're starting to see people being happier, working longer, being more involved, starting to have more time for other things like teaching. These 4 new medical schools require doctors to do a lot of teaching with patients, and that takes time. So finding more balance in the profession, I think, is what some of these tools will allow us to get. But it will be incremental. It won't be a revolution. We're not going to have an Uberification of healthcare based on a single app or product. We still have a lot of work to do with our existing technology, our EMRs, our hospital information systems. They largely, at least in the EMR world, in the community, have not changed in 20 years. Like, the products we're using now are still basically the same products we started with. And there's a tremendous amount of work can be done in making those products themselves better. Um, that's going to take a lot of energy, time, and effort, plus also probably some funding, and in a publicly funded system, that funding may well need to be more centralized. So I think we're going to start seeing some conversations there. I've been writing about that in the last week around a series of blogs called Rise Up about what we need to do to start fixing these problems, not just talk about them, start fixing them from the healthcare system, from physicians, from our colleges and educators, from our universities, from our regulators, from our technology companies. What do we need to do together to actually make this happen? I'm starting to move from the idea of what's not working to how do we make it work? And we got to get to that point really, really fast.
Yeah, no, and I'll definitely link the blog so you guys can access
Well,
it.
thank you.
The next question I have, it might be a bit more personal, but as you were sharing, how the automations to, help with the burnout, because there's been a lot of clinician burnout with physicians and nurses, all what have you. And so that being said, for you, and a lot of the times you'll see on LinkedIn where a lot of clinicians, physicians, nurses will share where it does take a toll on them. And then a lot of more of the seasoned physicians and nurses are still practicing, even though they may be, ready to retire, because they want to continue serving. So for yourself, being more seasoned, do you continue to practice because your love for medicine? Because we've seen a lot of physicians, the newer ones or more, the less seasoned, saying it taking a toll that they've kind of lost that passion. And so that's one side of it. The other side being because you are in the more of the health informatics space or what have you, that you want to see and be actively involved so you can disseminate that knowledge, whether it's through your blog or have that impact because you are in more senior leadership roles where you can empower other clinicians and have that impact. So just wanted to ask from your perspective, given, is it because of that you continue for that passion for medicine or wanting to still have that impact, or because there is a shortage? So I'm cognizant that this may be personal, but as you were sharing it, I was like, like you still are going at it. And so
Yeah.
a lot of clinicians aren't. So yeah, if you could just shed some
Yeah,
light and share with the audience.
I
Yeah.
don't think it's too personal. I think it's a multi-layered question and series of answers, though. So, like, I've always, first and foremost, loved patient care. It's what I want to do since I was this tall, and I'm definitely not that tall anymore. So, I just wanted to be involved. I want to get my hands in. I want to interact with people. I'm a very social person in the first place, and my first best love is sitting in front of a patient, solving a problem with them. So, I never wanted to lose that, even though I did a lot of work in health administration and in government kind of policy and in thinking and in teaching. And I think being able to wear those multiple hats at one time is a challenge. It doesn't always go very well because sometimes you just get too busy and you have to figure out how to let a few things go. But for me, patient care was always supplemented by my ability to be president of our hospital or to sit on a board of our foundation or to now be the chair of the federal cancer agency. Like these kind of health system level thought processes directly relate back to my care as a patient and my care with patients and vice versa. So that's just kind of how my mind has worked. I certainly have gone through times when I've been really, really tired. I never can remember a time of being actually burnt out, but that's probably because from the very first day of me practicing, I always had something else I was doing at the same time, which was medical, but not directly in front of patients. That's just my mind. So I've always had these things happening in parallel, and where one is getting too crazy or too tough, the other seems to buoy me up. And not all that goes well all the time, but I've rarely had this circumstance where those two collide and I'm just done. Now, I think one of the things we have in our profession is it's so overwhelming and so busy and so able to consume you for every ounce of your day and thought process. And we're dedicated to this task. We want to do better and we're highly perfectionistic and we're highly competitive. We don't do a great job as a profession, I think, of giving ourselves a break and saying, I need to step away. I need to reduce. I need to have another thing that I think about that isn't this, that gives me I guess, the balance or the lift that lets me put more energy back into that thing. So, and it'll swing left and right, and you'll never be exactly where you want to be. But that swing is also okay because over time, if you've gone too far in one direction, you'll come back to the middle again, and you're more able to make that happen. So now, as I'm getting into my more seasoned years, as you would put it, clearly evident by the gray beard and the gray hair, I am much more confident at being able to make choices about stopping things that no longer serve me and really promoting the things that serve me well. Partly that comes with the luxury of the freedom of having had a really substantial good practice over a long time, being able to morph it because I've always worked in a very dynamic group of doctors that support each other and allow each other adequate time off for vacations, cross coverage when we're there, really strong dynamic of asking each other questions, like a truly collective environment in my first practice in Thornhill. And then in my later years at Women's College Hospital, I've always been able to be in that environment where I felt supported. So I think as we start coming together in bigger groups and the teams start to actually gel, a lot of that feeling of being lost and burnt out and being alone is going to dissipate. And for the next generation of doctors and nurses coming through the pipeline, that's what gives me great hope for them. Is they're not going to be working in their little tiny silos in their little offices in the strip mall in picked, suburban town X. They're going to be working together both virtually and in real time with people that are not all doctors. They're going to be working with lots of other health professionals. They're going to buoy them up and make them smarter and actually add to their skill set rather than being the sole individual that is relied upon for everything. So I think it's a bit of a personal journey that we all have to go through. And I always joke that like all of my medical friends, and I have a lot of medical friends, all of them are really high performing physicians. And I can't think of one of them that's actually burning out right now. And then I like, what's the secret sauce? I mean, make no mistake, they're all really busy and they all have a lot going on. And sometimes they're just really, really tired. But in terms of actually burning out, I don't actually have one friend that's burning out right now. And I think that's because we probably aggregate and come together in the same kind of work pattern where we have our real love of patients. We also teach. We also, in some cases, do research. I don't, but many of them do. We also have charities on the side. We also do work at the governance level for, let's say, a hospital or a health system or a community health center, or you name it. It doesn't actually matter. But all of us have an also, and each one of those buoys up the primary goal of serving patients well and having a really robust practice that hopefully has legs for a long time. Now, that doesn't mean you're going to stay in the same job for 40 years of your career. You may switch jobs, and that job hopefully will always be something that's of interest to you and gives you a bit more energy. And what I've learned over time is like, if something really isn't working for me, I need to stop it and walk away from it. Hopefully handing it over to somebody who has more energy for it. But, I've been through a few different positions non-clinically in my lifetime that all of which I've learned from dramatically, some of which have been really great for a time and then weren't great after a while. And it was hard to let go, but letting go is freeing and moving on to the next thing as soon as that one ends is like almost instant. You don't even have to look for it. It just kind of comes your way. So I think for me, in summary, this comes from endless curiosity. It comes from still being really strongly tied to my core reason for doing this in the first place, which is I simply love patient care. And now that I'm even only doing 2 days a week of that, it's the best 2 days of my week. And I look forward to it every single week. And that's because I'm no longer in this location the chief of anything. I'm not the guy in charge. I'm the one who shows up, sees patients, makes everybody happy, looks after difficult problems, and gets to go home with a smile on my face. And that is a privilege, but it's one that you have to really work at.
Yeah, no, and thank you for sharing that. And the reason I wasn't saying seasoned because of the beard, I
I'm
was just,
joking. I'm
yeah,
joking.
no, no, no.
Oh, listen,
But
I'm embracing my age. Look at this.
no, absolutely. But I think I appreciate you kind of opening up and showing the human side of it. And that was kind of the purpose of asking you that question. I know you're very open. And so I had a feeling you would kind of open up and share that. And the reason for asking that question is for audience members that are clinicians who may be more seasoned, who may be, reaching burnout, or those who are students who are thinking of becoming clinicians. And we hear a lot of this when it comes to burnout, whether it's our nurses or physicians, you name it. And so by asking you this question is to kind of pick at that to understand how you have been able to, even being more seasoned and practicing, done so much in your career, to still be wanting to be practicing medicine. So I think the idea was to hone in on that and show the human side of it and a little bit of your personal journey. So any of you in the audience that could take some of that away and can apply it and resonates with you, because we need our clinicians, we need our nurses, our docs, our physiotherapists, you name it. And so we need you. And so to how to keep you guys moving forward despite a lot of that that's happening. And so I think sharing that human personal side was very important. So thank you for being open and sharing that.
Thank you.
I'll wrap up with one last question and we'll bring it back to the FHLIP conference. And so there's so much happening. We talked earlier that it's evolved. We have a startup section, we have live podcasting, we
Yeah.
have keynotes, panels, presentations with our students, other leadership within the healthcare ecosystem, various organizations, large sponsors, all of that coming to the table. From your perspective, what are you looking forward to? What you're excited for, or anything you want to share with the audience?
Yeah, I mean, there's a few things. One is, through the teaching in the various classes I've been involved in the MHI program, I've had the privilege of working one-on-one with some of these student groups that are now presenting. So I'm really looking forward to seeing that 1 or 2 years of work actually now coming to a head and being visible, and seeing how they've risen up and actually created something really special. So that's the first love I have. I'm super interested in our keynotes. Like, I've worked with Daphne Carr for a long time, from probably almost 20 years now, when she was at Cancer Care Ontario. She's brilliant. I was excited when she got this new role at the ministry. I can't wait to hear from her how she's going to be thinking about digital transformation writ large within the ministry and our government portfolios. I'm really looking forward to the networking part. The location we're at is big. We have space. We have a fantastic auditorium for learning. We have side rooms for the smaller sessions and the poster sessions. We have lots of networking environment. We have good food. We have a networking session, a startup zone. I think there's good reasons to be there, whether you're a student, a seasoned professional like me, an administrator, a government leader, anywhere in between. We have a place for you there. And this is a conference which is just simply going to be fun. And I think we're going to come out of it with a big smile on our face, all of us, and having seen something different actually happen. And then hopefully built up a few new contacts and maybe a few new bright ideas that will move into the next year or 2 years or 3 years of interesting things to have happen. This is the potential of this conference, which is different from any other conference I've been involved in. And there have been a lot. So I'm excited about that.
Yeah, no. So for those of you in the audience, definitely grab your tickets for the FHLIP Conference on February 20th. As Darren mentioned, there's so much for you to look forward to. There's something for everyone. It's a platform where we've been able to bring all the stakeholders to the table. It's amazing to be able to even say that. So a lot of exciting things happening. So make sure you do grab those tickets, and we hope to see you on February 20th. As we wrap up our conversation today, we talked into so much. We discussed the FHLIP Conference to give you a taste of that. And then we dived into, as I promised, I did pick Dr. Darren Larsen's brain so we could understand a little bit more on his perspective and things that we can learn, some of the challenges, things to look forward to from all aspects. So that's just a taste of some of the conversations that are going to be happening at the FHLIP Conference. And so as we wrap our session today, Darren, I just want to hand it over to you in case there's anything else you want to leave the audience with or anything you want to touch on before we wrap up for today.
Yeah, we've done a great job of covering a lot of topics, but I really want to leave with, I think, the idea that I'm truly optimistic about the future of healthcare in Canada, because partly because I get to work with so many bright young people that I know will be our future. And I see how invested they are in trying to make things better for the profession, for the healthcare system, for their patients. And that gives me great hope. I don't have a great need to be a patient right now, but one day I will need to be a patient. And I look to these people that are building really brave new ideas and putting them into practice to be the future. And it's a joy and privilege to interact from the teaching perspective. It's a joy and privilege to watch some of these projects come to life. And for me, I'm actually optimistic, even though we're all working really, really hard and some of us are really, really tired. A lot of us are still able to do this with a ton of joy and feel really good about our day and that we're contributing. So I always reflect back to purpose. And, if you're able to have that joy, you feel like you're making a difference, that you're contributing, you're watching others grow around you. What better thing is there in life?
Yeah, no, and thank you so much. It's a beautiful way to end off our session today. And so once again, thank you so much, Dr. Darren Larsen, for being our guest a second time in a row and sharing your knowledge. And so thank you so
Third
much.
time's a charm, Fahreen. We're going
Yeah,
to get it right the third time. So
oh yes, definitely. So that's those of you heard that. So third time he's going to show up, and so hopefully we'll be able to get a couple more nuggets from him over time. So yeah. So once again, thank you. And for those of you who have not subscribed to Empower Speaks, please do so you do not miss such wonderful conversations in the future. So I'll just wrap up once again. Thank you, Dr. Darren Larsen, for your
thank
time,
you.
and third
It's a
time's a
pleasure.
charm. So we'll bring you again. Thank you.